This is RadPod, a podcast produced by ASMERT, the Australian Society of Medical Imaging and Radiation Therapy. ASMERT acknowledges the Bunurong people as the traditional owners of the land from which we record this podcast and pays respect to elders past and present. Hello, I'm Steve Lacey and I'm the Director of Education for ASMERT. Now, most of you listeners out there would be radiographers or radiation therapists, nuclear medicine technologists, or maybe even students in this field, and you'd probably spend many of your working days just going about your regular business. But how much do you think you take your work for granted? Have you ever thought about the working conditions of your counterparts in low to middle income countries? Well, today I'm joined by two guests who have seen these conditions firsthand. My first guest is Craig Opie. Craig is a radiation therapist from the Royal North Shore Hospital in Sydney and has worked with the International Atomic Energy Agency, and from here on in I'm going to be calling them the IAEA, and he's worked with them on educational projects in low to middle income countries. He's also chair of ASMERT's Global Medical Radiation Practitioners Reference Group. Welcome to the show, Craig.
Hi, Steve. Thank you for having me.
Our second guest is Jacob Argo. Jacob obtained his undergraduate degree in radiography in Ghana, and he has practiced clinically in Ghana as well as in Norway, of all places, where he also did his Masters in Radiation Health Physics on exchange. And Jacob's currently here in Melbourne undergoing his PhD. Welcome, Jacob.
Thanks, Steve.
Now, Craig, I just want to start with you. You've done some teaching in low to middle income countries with the IAEA. Can you just tell me a little bit about this?
Yes, I can. Look, the IAEA project I'm part of at the moment is called AstroNet. It's been going for about 4 years, where we have a series of online seminars that are regularly held with a radiation therapist audience in mind. We have been able to collaborate with passionate radiation therapists in low and middle income countries in the Asia Pacific region to host these seminars for anybody who wants to join. I've also done a lot of teaching in low and middle income countries by actually being there, primarily in Myanmar, but I've also done some teaching in Vietnam and Cambodia all over about the last 10 years or so.
Mostly kind of confined to Southeast Asian countries?
Yes, that's right. Groups I've worked with have certainly had an Asia-Pacific focus, and that's where most of my work has been done, but also I've connected with colleagues in Ghana in just the last few months and been assisting them there in the two main cities in that country.
All right. Well, so speaking of Ghana, Jacob, this is obviously where you're from. You've got lived experience working in a low to middle income country, obviously, which is Ghana. Can you tell me some of the challenges of these types of countries that you can come across?
Yeah, so I must admit that working in low-income country, it's very challenging and quite frustrating for some of us doing radiography, because most often the equipments are not there. Yeah. And the ones that are there, servicing it's very, very difficult. They do not really undergo servicing.
Okay.
Yeah. And apart from the equipment, which is the X-ray machines and the CT and MRI that are not available, sometimes even the small equipment, that the things that we need for day-to-day activities are not there.
Right.
And recently I was doing a research, and one of my students said they couldn't even go for placement because the center said they did not have envelopes, they did not have films. So they can't go for the placement. And so the school has to go in and purchase some for them. And even in the cities that have most of the equipment, it's usually very, very rare. It's either the equipment are worn out or they are there, but they don't have people to really teach the radiographers on how to utilize some of these advanced equipment. So it's very, very challenging in some part of Ghana.
So I've got some questions that have come out of this little bit here. The first one is, you talked a little bit about the servicing. So equipment doesn't get serviced and that. What happens if something goes wrong with the equipment?
Yeah, so recently the application specialists are coming up, but there are very few in the country.
Yeah.
So some equipment can break down for about a year. They will not service it. It means that it's not working. And even for Kolebu, that the main hospital in Ghana, there was a time that the CT equipment was not working for about a year. It has to take private partnership to come in to supply them with a different equipment. And when that happens, the amount that patient has to pay goes up because it's not coming from the government. There's a private setting, even within Kolebu. Yeah. So they have the private partnership that they're working with, and that is when they have to be able to do the imaging. Sometimes patients have to travel all the way from the north, Tamale, to Accra, because the Tamale equipment is not working. Okay. Or maybe Konfanoche is not working, so they all have to come to Accra.
So if the equipment's not working, people will then have to either travel, or is another alternative just to use a different imaging modality? So instead of saying, look, this patient needs a CT, But at the moment, all we've got available is general X-ray. Can we just do that instead?
What happens if we do the X-ray and then the specialist says, I still need a CT?
Exactly.
What happens? So eventually they would have to do the CT, but they have to now travel all the way from long distances to Accra.
Yeah.
And because of that, radiographers do not even want to go to the hinterlands, what we will call rural areas here.
Yeah.
So it's very, very challenging for the radiographers and for the patient that we are taking care of as well. Because if they don't have people to take care of them, if the equipment are not there, what happens to their health? They have to travel all the way from the north, all the way from other parts of the country to either Accra or Kumasi. And the road network is also not good. So even if the road network is good and you are traveling, you know that, okay, it's something that you can just do and come. But the road network is not good. You're just going for an X-ray and you have to travel all the way for about 6 hours. It's very frustrating. Yeah.
And not only that, it would also have an effect on the CT scanner that they're traveling to as well, because then all of a sudden the workload of that CT scanner will increase. And so that adds to the pressure that's already on that particular scanner itself.
Exactly.
So I went to Mongolia a few years back for a project to look at the way that radiographers took chest X-rays in children, and they had similar issues with equipment where it was new equipment that was donated by a vendor or another country, but they didn't actually have any app support or servicing or anything like that. They just basically said, here's a machine and that's it. So if that machine broke down, it was then up to the hospital maintenance crew who could do maintenance like changing light bulbs or whatever else they would do. It was up to them to fix it, and they had no knowledge of the engineering behind this equipment and that. So all of the servicing and the fixing of things was relatively basic, I think, anyway.
So apart from this equipment that are not there, even sometimes some of the equipment are there, but we don't have that knowledge because the equipment are always advancing. So technology is advancing the equipment. We have new technologies within. Because once I went to a facility here in Melbourne, and I realized what they were doing. I know that I had the technical knowledge, but the swiftness and the speed with which they completed the examination, I was like, are you done? He said, yes. I said, wow. Because everything looks automated. And in Ghana, it will be very difficult. Maybe some few hospitals, very advanced ones, have the opportunity. And aside these things that are peculiar to people in this part of the country or this part of the world, there are also issues with burnouts because we don't have the radiographers, we don't have the equipment there. So because we don't have a lot of staff, there are issues of staff burnouts. So the radiographers easily get tired working because you have to work from one facility to another facility to take care of the patients, and becomes so challenging for them. As well as you are confronting patients that are very challenging to deal with. So all those issues with low and middle income countries, even though some are peculiar to low and middle income countries, just the same as what the advanced world also experience.
Yeah.
Those of us also from the low middle income countries, we also experience the same thing.
Yeah.
We experience issues of burnout.
Yeah, you're right. So basically what you're saying is that all of the issues that we experience on a day-to-day basis in our own jobs here in the developed world, they're still feeling those in low to middle income countries as well, but they have the added issues that they've got in terms of the servicing of equipment and people having to travel for it and that. It's unbelievable. What about the staffing issues within a place like Ghana? Like, what are they like?
So now, because everyone wants a better job offers, they want better income, people are now moving out of Ghana to UK. Basically, most of them go to UK.
Yeah.
So it now brings extra layer of stress on the few remaining radiographers in the country.
Yeah.
Because the living conditions are very poor for the radiographers. And that is why most of them will not even want to go to the rural areas, because over there, then the life is very, very, very bad.
Yeah.
Because if someone in Accra is complaining, then what happens to someone in Tamale or someone in Boko that is far from Accra, about 7 hours drive from Accra?
Yeah, right.
So because of the low income, people are now driving away, going to UK, looking for opportunities everywhere. So yeah, that's the main thing with the staffing issue.
Yeah. Okay. So there's not a lot of staff there because they all seem to be kind of going elsewhere to look for something that's actually going to give them a much higher income and to support their families. Yeah. An interesting fact that I heard a few years ago as well was that in Rwanda, for example, there's actually only 19 radiologists in the entire country, and they're all based in the city. So that means from a mammography perspective, that means there's actually no mammography services in rural Rwanda at all. Anyone that needs a mammogram actually has to travel to the capital city in order to be able to get a mammogram. And so you can imagine what that's actually going to mean for healthcare, particularly in that area.
That reminds me, Steve. So one of my seniors, he's working here in Australia. He's teaching here.
Yeah.
And he's doing his PhD back in Ghana, and he's working on radiology shortages in Ghana.
Yeah.
So when we were analyzing the data, I realized that sometimes it can take up to 3 days, 4 days before they get reports.
Yeah.
Sometimes it never comes because they don't have radiologists at all. And from my personal experience, when I started working, even though I was working in a private center, that it can take about few minutes for you to get the reports.
Yeah.
Initially, our report used to take 2 days for us to get, whether it is emergency or not. Sometimes you have to call the radiologist that, oh, this case is an emergency. Can you quickly look at it for us? What happens if he's busy somewhere? It means it's going to take a lot of time. And so later on, we had another radiologist who could do it for us within a day for a private center. So that issue is also very prevalent in the low and middle income countries.
Yeah. Craig, what about working conditions for radiation therapy? I mean, I assume that they would only really be based in the main cities too. What's that like?
Yeah, look, much of what Jacob has just described for radiography is the same for radiation therapy in low and middle income countries. And again, Myanmar is where I've had the greatest amount of experience. Yes, radiation therapy centres are concentrated in the main cities, in provincial capitals or the national capitals. And as Jacob described, people need to travel a long way to have their radiation therapy treatments. It just has to happen that way, and that creates major inconveniences for them. And much like what Jacob was describing, they'll be faced with situations where they need to give up their work or something like that.
Yeah.
They might be travelling to a city where they can't find accommodation that's affordable for them, or they don't have friends there. Sometimes there's charities that can assist with that, but not very well. So that these sorts of things really present challenges to patients. And apart from that, the workloads at these radiation therapy centres are very high, probably quadruple of what you'd see at a typical radiation therapy centre or higher in Australia.
So how do they manage that? How do they manage the increased workload?
Extended work hours is one thing, which is not good for patients who are sick, nor is it good for averting burnout in radiation therapists or other clinical staff.
Absolutely.
So there's that. And also simplifying their clinical procedures.
Yeah.
And that makes it very difficult to have any sort of innovation and positive change as new technologies come through.
And lowers the quality of the actual treatment that they're
Absolutely.
getting as well.
It lowers the quality of the clinical practice in general terms. And that's something that's a constant feature too, where their workflows are really challenged by a lack of training, much like Jacob described. And so that means that there's not very much inbuilt quality assurance and quality control with what's being done.
Yeah.
The radiation therapists, there's shortages of them. That's something that I've published on by comparison with world standards that have been developed by the European Union and the IAEA. And also their pay is quite poor, so there's a disincentive to stay as a radiation therapist when, for example, in Cambodia, you could go away and be a high school science teacher and earn double the pay.
Yeah, right.
So that makes it very difficult to both attract and retain radiation therapists. And there's no specific training for them, much like what we were talking about with engineering staff when there's machine breakdowns or servicing that's needed. Those sorts of problems present themselves in radiation therapy and LMICs as well, where it's difficult to access those people who've got that expertise. They certainly wouldn't be situated in the hospital campus or clinic where the radiation therapy is taking place. They might need to travel from essentially interstate to make that happen.
Yeah.
If that is at a radiation therapy that's in a provincial capital. And they also have problems with consumables, much like what Jacob was describing, where these sorts of things run out. And there can be just really simple things to do with hygiene matters. Infection control, not having disposable wipes to wipe down a bed or something like that, or there's no such thing as linen services. The other thing that you might see too is patients need to pay for the consumables in a way that wouldn't happen here in Australia. For example, they pay for the contrast that they need for examinations, either in radiography or radiation therapy, which is quite a lot of money for them. It's maybe about $15 for a dose of contrast, and that's, maybe for many people that would be 3 days' wages.
And to add to that, a few years back, we obviously had a big contrast shortage due to problems that were associated with conflict. And that was a huge effect on the developed world. So you can imagine what kind of effect that would have actually had in the low to the middle income countries.
It would be even worse because they'll always have more difficulty sourcing these things and can be less competitive in that space.
Yeah.
If you add that together, that really presents problems. And for radiography, that's going to lower the quality of examinations a great deal.
Absolutely. And so what about the equipment that they were using with the radiation therapy in these countries? How is practice there different to the developed world?
it's much more mixed than the developed world. So you'll have radiation therapy centres with reasonably advanced equipment in the same centre as very old and outdated equipment.
Right.
And what's going on there is that since the turn of this century, the radiation therapy centres in low and middle income countries have generally advanced themselves really quickly because up-to-date medical linear accelerators and other equipment has become available on cost within the reach of their finances. But the clinical practices and the training associated with that haven't really kept pace. And so that's very difficult. That's another thing that's difficult is the radiation therapists themselves don't have degree training like you would see in developed countries.
Yeah. So for hospitals that have one piece of brand spanking new equipment and also another piece of equipment, how do they then determine which patient goes on which machine?
It'd be essentially by the anatomical site that requires treatment and whether it's a palliative or curative intent case.
Yeah.
That's mainly what it is. So it's disease category and anatomical site. And often those things overlap depending on disease staging.
Yeah. And, we could talk about this till the cows come home, but if we go into the training aspects of these professionals in these countries, there is already, we know, quite a big difference, not just between the developed world and the low to middle income countries, but even within low to middle income countries, some of them have very well developed training programs and others do not. And I must admit, when I was in Mongolia, one of the things that I found the most confronting was the way that they took their chest x-rays. So instead of using the conventional method that we know, they were actually laying the children down on a fluoroscopy table and screening the chests in real time with the radiologist watching, who wouldn't actually save any images. He would just write something in the notes, not store any images, and then send the patient off and then get the next patient on the table and do the same thing. So you're going to have low quality imaging with movement for these. You're going to have no storage of images for referral or comparison. And it was an absolute eye-opener for me. I really had to take a step back and say, these guys need some really significant training in actually how to take proper chest x-rays.
And it's probably a radiation safety dimension to that where they're probably getting a much higher dose than would otherwise be the case if you had...
Well, absolutely. And I also think that the way that they were taught was what I was informed was an old Soviet method of actually teaching it too. So, Jacob, when you do look at the education that the radiographers are receiving, do you think that we're looking at best practice methods, or do they just teach their own methods then?
Talking about best practice, that's very interesting for me. In Ghana, theoretically, I would say, yes, they do very well.
Yeah.
The academics do very well. But when they go on placement, it's not only about placement. It's about the learning that takes place on placement. And we don't have any framework to support work-integrated learning.
Yeah.
All we know is go out for placement. What happens on placement? What do students do? Are they supervised well? Because there's no framework, radiographers do not have any obligation to supervise. So depends on who you are with. Depends on which radiographer you get to work with. Because from my personal experience, my first 2 years in uni, I was not really seeing what we were doing in radiography. I didn't understand anything. And I was not doing well on placement. I was not doing well clinically until I got to a different place, and then the radiographers were very good, very welcoming. And I realized, so this is radiography. It's actually not as difficult as I thought. And at the end of the day, I was able to come out as the best clinical student. So it depends on who you are working with. But here lies the case. In Ghana, we don't have a framework. Students are just pushed out to go on placement and they are not supervised well. They don't have that kind of effective supervision to be able to learn on placement.
Yeah.
Now, in one of my research that I did, I followed the best practice clinical learning environment in Australia. When I came here, I understood that they have this framework that they follow. So I used that framework to study what happens in our placement settings in Ghana. And the students were like, when we go, they just watch us and do what you want to do. So the radiographers will say, just watch me do it and then follow it. So we titled that paper, Watch Them Do What They Do. So if the radiographer is not doing the right thing, the student will just pick it up.
Yeah.
And then it will pass on from generation to generation. And the radiographers are not willing to change to current practices. So it becomes very, very challenging when it talks about best practice.
Yeah.
Because even though they are getting the theoretical things right, clinically, they may not be getting the things right, but they are just sent out and then they will just get a feedback that, okay, I went for a placement, this is my assessment, and that is all. So I think that if they can get some collaboration to be able to develop a framework to support, that will be good. And that's something that I'm very keen on doing because without that, we'll just be producing radiographers, but they do not have, the best practice skill in them. they just have the knowledge, but for them to be able to practice effectively, they have to learn on placement once they are out of school.
So really the skills, I guess, that the radiographer will be based on how well they are taught.
Yes.
And they're basically taught without a framework. It's pretty much how their supervisor was taught is pretty much how they're going to be taught.
Exactly.
And so whatever skills the supervisor has is the only skills that they're going to have. So if the supervisor's skills are no good, their skills are going to be no good. What about you, Craig? Is it the same for RT?
To some extent, yes. I think that there's certainly literature that points to work integrated learning occurring at a much higher quality if you have staff who have teaching skills. And I'm really glad you brought up the point, Jacob, of having a learning framework for clinical settings. That really assists a lot too. And look, in my experience, that's varied from country to country. I'm pleased to say that when I was in Myanmar, they did have a work integrated learning framework in place for radiation therapists. It was 6 months on-the-job training, and there was selection criteria to be able to enter that, which were reasonably rigorous. However, it fell to people who were interested in delivering that learning rather than it being considered a core part of practice. And in some countries, there's just nothing at all, and they really have trouble attracting and retaining staff, and there's no frameworks at all. So it really is a bit of a mixed bag and is dependent on things outside of medical radiation science about how successfully that is carried out or not.
Yeah, I think there's also a lot of international organisations that have done a lot of work in terms of researching the differences between different countries. And I'm even talking even amongst across the developed world as well as low to middle income countries in terms of what their programs actually look like. There's a huge variation. Some programs run for as little as 2 years or even 1.5 years, all the way through to 5+ years. And within those, we also have to look at the scope of practice. RT is probably a big issue, I guess, because RT seems to be embedded within a lot of medical radiation practice programs whereby a radiographer is going to come out and is expected to do the work of a radiation therapist. And I think that actually makes it quite difficult because with the huge variation around the world, it really creates a big problem as far as what I like to refer to as professional identity. Because people who are not radiographers or radiation therapists don't necessarily understand the role of a radiographer and radiation therapist because there's such a variation on a global scale. And I think that's something that we really, really need to work on. So now we've talked a lot about how this is a big problem and how there's a clear disparity with access to good healthcare between low to middle income countries and the developed world. Let's talk about how we're helping this. So Craig, you're the co-chair of the ASMERT Global Medical Radiation Practitioners Reference Group. Can you give us an outline of what ASMERT is currently doing to support these countries?
Yes, we're making some progress there. The Global Medical Radiation Practitioner Reference Group is setting ourselves up to be a bit of a brokering force between people who can contribute and people in low and middle income countries or organisations within low and middle income countries that could benefit from some sort of assistance.
Yep.
And we're trying to form partnerships with existing organisations to enable that sort of thing. So that would be with groups such as Australian Volunteers International, and also with some Australian universities. There might be contributions that can be made. The ways that this could happen would be by having Australian radiographers and radiation therapists placed in teaching roles for periods of time in low and middle income country settings. It could be that we could host radiographers and radiation therapists from those same countries here in Australia for a study visit. Or conference attendance or something like that. Also, you can have remote learning programs, much like what I've done and described before with the IAEA. We could have online seminars that can be of some sort of practical assistance. And also, it could be with learning resource creation from here in Australia targeted at either our colleagues in low and middle income countries or as preparatory resources for Australian radiographers and RTs who are going to visit those countries. They're the sorts of things that we're working on now and hope to expand quite a bit more over the next 5 or so years.
And the IAEA also does some work with other organisations within Australia, as well as through projects with the International Society of Radiographers and Radiological Technologists, which is the ISRRT. It's also important to note that those who want to go and volunteer to help can actually do so by linking in with groups such as Radiology Across Borders or RAB, as well as RadAid too. And I think that for those people who are ASMERT members can probably look to see what's happening in that ASMERT space, and because I think that ASMERT's going to be calling for those types of volunteers to be able to help with these types of projects.
Absolutely. I'm so glad that you mentioned RadAid and Radiology Across Borders. Medicine Sans Frontières is another group that's expanding into the radiation oncology space right now.
Yep.
And Radios Contra Cancer is another one. And there's a large number of groups already doing good work and who are accomplished in this space, who the Global Medical Radiation Practitioner Reference Group can probably link interested parties up with better than ever before.
Yep. And Jacob, what are some other ways that we can help support these countries?
Yeah, so I think the collaboration aspect is key. If we can collaborate with them on how to train students and how to even develop their curricula, it will be very, very good. Recently, I've seen that there are some organizations that have joined hands with the Radiographers Association in Ghana. So they teach them MRI stuff, and then there's radiology across borders. I can see some of the boys in that activity as well. So I think that is also helpful. One of the key things is how they can even assess students. So I'm working with some researchers in Australia. We're looking at the assessment strategies across low and middle income countries, and if they will be willing to come into collaboration to help develop an assessment criteria for the radiography and radiation therapy student. So I think basically it's about collaboration and online seminars. That will also be good for them, because that's the main thing that they will need to improve on their knowledge. If they have this online platform where they can go and learn, and if institutions in Australia, academic institutions, can offer support in terms of simulation softwares, that will also be very, very good.
Yep. Absolutely. And from a remote perspective, there are plenty of online resources that can also allow for online training as well as webinars and things like that. So if you're wanting to help and you've got something to give or you want to present on something, then get in contact with groups such as the ISRRT or Radiology Across Borders, who do run the regular webinars and are often seeking presenters for these. And for those people who are living in low to middle income countries and interested in working in countries such as Australia, I would suggest that you go to the ASMERT website and look for the overseas qualification assessment standards, but also have a look at the webinars, have a look at those things that these groups are organising that are available to anyone in the world. Craig and Jacob, thank you both for joining me today and highlighting the work that our medical radiation counterparts are doing in these countries. Any last minute thoughts for our listeners who might be interested in helping out?
Just from me, I think that there's been a lot of progress made with collaborations between Australia and other developed countries and our colleagues in low middle income countries. We've just talked about directions that we can take. Get on board, everybody. We really can make a difference over time.
Yeah, absolutely. Jacob?
Yeah, we would just ask that if anyone has any help for people in the low and middle income country, they should be willing to help them, because at the end, we are looking for the safety of the patient. We are looking for good quality healthcare for everyone. So if anyone has any support of any kind, can reach out to the ASMERT Global Medical Radiation Reference Group and then help these people.
Wonderful. Thanks, guys. Great chatting with you both.
Thank you.
Thanks for listening to RadPod, a podcast produced by the Australian Society of Medical Imaging and Radiation Therapy.